All right, this is a short voiceover regarding the documentation and informatics chapter. So the purposes of the medical record. So data entered into the medical record facilitates communication, provides a legal record of care provided by nursing and other healthcare disciplines, justifies financial billing and reimbursement, and allows for auditing, monitoring, and evaluation of the care provided. Medical records serve as sources of research data and as learning resources for all healthcare members. Information communicated in a patient's record allows healthcare providers to know a patient thoroughly, facilitating safe and patient-centered clinical decision-making. Mistakes in documentation that commonly result in malpractice include failing to record pertinent health or drug information, failing to record nursing actions, failing to record medication administration, or drug reactions or changes in patients' conditions. Incomplete or ineligible records. Hospitals establish quality improvement programs or projects for conducting objective, ongoing reviews of patient care and to keep nurses informed of the standards of nursing practice to maintain excellence in care. The Joint Commission requires self-regulation and quality improvement actions. Researchers use patient records to gather statistical data on the incidence and prevalence of health problems, complications, the use of specific medical and nursing interventions, and the outcomes and recovery from illness and unfortunately deaths. A patient's record contains a variety of information, including diagnoses, manifestations, successful therapies or unsuccessful therapies, diagnostic findings such as laboratory results, chest x-rays, and patient behaviors. An EHR, or the electronic health record, is a digital version of the patient data that is found in traditional paper records. The term EHR is used increasingly to refer to a lifetime record of all healthcare encounters for an individualized patient. The EHR is the legal record that describes a single encounter or visit created in hospitals or outpatient settings that is the source of data for the EHR. To meet standards, EHRs are expected to have the following attributes or components. They need to provide a lifetime patient record by linking all patient data from previous healthcare encounters. Include a problem list indicating clinical problems for each healthcare encounter, the number of occurrences associated with all past and current problems, and the current status of each problem. They need to require the use of standardized measures to evaluate and record health status and functional levels, provide a method of documenting the clinical reasoning or rationales for diagnoses and conclusions that allow clinical decisions making to be tracked by all providers who access the record, support confidentiality and privacy and audit trails, provide continuous access to authorized users at any time, allow multiple healthcare providers access to the patient data at the same time, support links or remote information resources such as databases using the internet or intranet resources based within an organization, support the use of decision analysis tools, support direct entry of patient data by physicians or advanced practice nurses, include mechanisms for measuring the cost and quality of care, support existing and evolving clinical needs by being flexible and expandable. The promise of the EHR is twofold: making a positive impact on the quality of patient care through interdisciplinary collaboration and improving patient safety through the use of clinical decision support. Accurate documentation within EHR facilitates interprofessional communication, helps to meet professional legal requirements, and aids in quality improvement efforts in healthcare research. The key advantages of an EHR for nursing includes a means for nurses to compare current data about a patient with data from a previous healthcare encounter and to maintain an ongoing record of healthcare education to a patient and the patient's response to that information. Regardless of whether documentation is entered electronically or on paper, each member of the healthcare team needs to document patient information in an accurate, timely, concise, and effective manner. The healthcare environment creates many challenges for accurately documenting and reporting the care delivered to patients. Whether the transfer of patient information occurs through verbal reports, electronic records, or written documents, you need to follow some basic principles. Only members of the healthcare team who are directly involved in a patient's care have access to the medical record. Patients have the right to request copies of their medical records and read the information. The actual database that holds the data or the information or the paper chart is the healthcare organization's, but the information that's in there is the patient, and they have the right to see it at any time. The Health Insurance Portability and Accountability Act, or HIPAA, of 1996 was the first federal legislation providing protection for patient records. It governs all areas of patient information and management of that information. It requires that disclosure or request regarding health information be limited to the specific information required for a particular purpose. Sometimes nurses use healthcare records for data gathering, research, or continuing education. As long as a nurse uses a record as specified and permission is granted, this is permissible. You can review your patient's medical records only for information that is needed to provide safe and effective care. Not only is it unethical to view medical records of other patients, but breaches of confidentiality lead to disciplinary action by employers and dismissal from work or nursing school. So the moral of the story is your neighbors or your family members, unless they have actually written a release that you can have access to it, is not any of your business. So if your family comes into the hospital or comes into the floor that you're working, unless you are directly responsible in caring for them, you don't have the right to log in and look at their information. So protection of information in computer systems is a top priority. Under HIPAA, ensuring appropriate access to and confidentiality of protected health information is the responsibility of all people working in healthcare. Other security measures include firewalls and the installation of antivirus and spyware detection software. A firewall is a combination of hardware software that protects a private network. Physical security has limited benefit, especially if an organization uses mobile wireless devices, such as notebooks and PCs. These devices are easily misplaced or lost, falling into the wrong hands. Some organizations use motion detectors or alarms with these devices to help prevent theft. Access or login codes along with passwords are frequently used for authenticating authorized access to medical records. Disciplinary action, including loss of employment, occurs when nurses or other healthcare workers inappropriately access patient information. And not only that, you do not need to be sharing your login information with anybody else. That is your information. Destroy anything that is printed when the information is no longer needed. Anything that has personal or patient health information on it. You need to de-identify all patient data when you write it onto forms or included in papers written for nursing courses. So the patient's name, their date of birth, their medical record number, their address. Historically, the primary sources for inadvertent, unauthorized disclosure of PHI occurred when information was printed from a patient record and faxed to other healthcare providers. Destroy all printed material after faxing. The following are steps to take to enhance fax security. Confirm the fax numbers are correct before sending information. Use a cover sheet to eliminate the need for the recipient to read the information to determine who gets it. Authenticate at both ends before data transmission to verify that sources and destinations are correct. Use programmed speed dial keys to eliminate the chance of dialing error and misdirected information. Use the encryption feature on the fax machine. Encoding transmission makes it impossible to read confidential information without the encryption key. Place fax machines in a secure area and limit machine access to designated individuals. Log fax transmissions. This feature is also available electronically on the machine. Each healthcare organization has standards that govern the type of information you document and for which you are accountable. Know the standards of your organization to ensure complete and accurate documentation. Your documentation needs to conform with the standards of the National Committee for Quality Assurance and the accrediting bodies such as the Joint Commission to maintain institutional accreditation and minimize liability. Current documentation standards require that all patients admitted to a healthcare facility have an assessment of physical, psychosocial, environmental, self-care, knowledge level, and discharge planning needs. According to current standards, your documentation needs to demonstrate application of the nursing process and include evidence of patient and family teaching and discharge planning, which always starts on admission. All medical records contain the following information: patient identification and demographic data, advanced directives such as living wills, power of attorneys, informed consent, admission data, any type of nursing diagnoses and care plans, a record of the nursing care treatment and evaluation, the medical surgical history, physical assessment findings, diagnostic study reports, and on and on. Quality documentation has 5 important characteristics: that it is factual, accurate, complete, current, and organized, so in chronological order. It is easier to maintain these characteristics if you continually seek to express ideas clearly and succinctly. Okay? This slide is extremely important. We need to make sure that we stick to the facts. Okay? If we're talking about something that's in subjective data, we need to make sure we're documenting it in the patient's own words. If we're documenting something that is objective, we need to make sure that we are sticking directly to the facts, accurately documenting the numbers and the measurements. Okay? We need to make sure that we write in short sentences, and this is often referred to as brevity. Okay? We're not really writing in full, complete sentences. It's more in fragments. Okay? Enough to get the point across, enough for it to flow and be easy to read, but it's not complete sentences, paragraphs. We need to make sure that we use simple, concise, short words and avoid the use of jargon or abbreviations that are not approved. A factual record contains descriptive, objective information about what a nurse hears, smells, or palpates. We always need to make sure that we're avoiding vague terms such as appears, seems, or apparently, or I think. We also need to make sure that we're not putting in our own opinions or perspectives, right? It's about what we see or what we hear, right? So factual, accurate. So the use of exact measurements establishes accuracy and helps you determine if a patient's condition has changed in a positive or negative way. It's essential to avoid the use of unnecessary words and irrelevant details. We need to make sure that ensure that the information within a recorded entry is complete, containing appropriate and essential information. Timely entries are essential in patients' ongoing care. That's the whole reason that we really use electronic health records as well. They want to make sure that we're documenting in real time, because the closer that we document to the time that things have been done, the more accurate they are. Most healthcare agencies use military time, and that's what we use and that's what we document on. We need to make sure that we document the following activities or findings at the time of occurrence. Vital signs, a pain assessment on a patient, administration of any medications or treatments, such as breathing treatments from a respiratory therapist, preparation for any types of tests, surgeries, any type of change in status where the patient has started to deteriorate. Anytime we've had to notify an advanced practice nurse, physician, a patient is admitted, transferred, discharged, or unfortunately passes away. So let's talk a little bit about the different methods of documentation that you'll see in the chart. And sometimes it's a little bit difficult to detail these, as now we're using them all in the electronic health record. So they're somewhat dispersed all throughout. So the narrative documentation is the more traditional method, okay? And it's like a story-like format, and it's more in a paragraph. It's kind of a free text. And so we use these not as much with the electronic health record as we did with the paper chart, okay? Because everything with the electronic health record is much more standardized, which is the benefit of it, right? If we can kind of conform, there's less variations in the way that certain things are being documented, and so there's less error, like room for interpretation errors. Less opportunity for double documentation where errors can be found. The problem with narrative documentation, because it's done in more of a free text or paragraph formation, it includes a lot of repetition, it's very lengthy and disorganized, and it takes people long periods of time. So we still do this in practice, but we don't have to do it as much with the electronic health record. Okay. So like we said, one of the limitations of the electronic health record is the limited use of narrative documentation. So we said some areas of the EHR use a lot of multiple checkboxes or drop-down boxes, which some believe may not adequately convey the details of some events. However, these checkboxes and these drop-down boxes all have the capabilities to add comments, insert text boxes. So you really can individualize and expand on what you're standardizing towards the patient. Another method of documentation is called the problem-oriented medical record. It's a method of documentation that is organized according to the patient's healthcare problems. The database contains all available assessment information, such as the history and physical, the admission history, laboratory reports, diagnostic testing, or radiological test results. After analyzing the data, healthcare team members identify problems and make a single problem list. Team members list the problems in chronological order and file the list in the patient's record to serve as an organizing guide for patient care. Disciplines involved in a patient's care develop a plan of care for each problem. Healthcare team members monitor and record the progress made towards resolving a patient's problems in progress notes. And these are often where you'll see different disciplines, such as advanced practice nurses, physicians, respiratory therapists, speech therapy, physical therapy, where they're writing their notes So we can get an idea, or we can get a sense of how is the patient doing or progressing. What do they think from their area of expertise? Some other methods that we use within the progress note, and it's how we actually format our documentation, um, is SOAP, SOAPy, PIE, or focus charting. Now, as nurses, we can use the SOAP style of documentation in a progress note, but that's most awfully with healthcare providers. Whereas if we have to do a narrative note versus writing in free text, we can do what's called a PIE progress note or a focus charting note. Like a lot of what we do is drop down boxes and check boxes, and we usually will put in a few comments or some narrative notes. But we can actually organize how we set up the narrative note instead of doing a free text in these types of templates. So PIE would be set up as such, like as problem, intervention, and evaluation. So problem would be something as simple as maybe nausea. The patient had nausea. Intervention would be like, what did we do for the patient? And then the evaluation would be like, how did the patient respond to what we did? Okay, so it just organizes a progress note. Another way to do it is called a focus charting. And sometimes we think of it as DAR or DARP. So data could be maybe a patient complains of having insomnia, right? They can't sleep. So action would be, what did we do for the patient to help them sleep? And then R would be, how did the patient respond to that action? And then we could also add something called plan right behind it. So plan would be, what do we plan to do? Are we going to follow up with the patient in an hour, or are we going to follow up with them in 2 hours? So the philosophy by charting by exception, which is what we do, is that a patient meets all standards unless otherwise documented. So this has become very popular since we started documenting an electronic health record. The predefined statements used to document nursing assessments of body systems are called within defined limits or within normal limits. They consist of written criteria for a normal assessment for each body system. You only write a progress note when a patient's assessment does not meet the standardized criteria for normal in one body system. So all it means is if you happen to be assessing the respiratory system and the patient is normal, there's no abnormalities, then you really, for that assessment piece, you just document within normal limits. So unless something is abnormal, you don't really document against it. Okay, so you could have a patient who's normal in every area, but maybe one, and so only in one area would you maybe be doing a lot of documentation, right? So it keeps things to the minimum, right? It saves time, saves energy. So when changes in a patient's condition develop, then you would need to include a thorough and precise description of the effects of the changes in the progress note. Okay. The case management model of delivering care incorporates an interprofessional approach to documenting patient care. Okay. Critical pathways are interprofessional care plans that identify patient problems, key interventions, and expected outcomes within an established time frame. So for example, if a patient comes in to have their gallbladder taken out, there may be a specific critical pathway for that all disciplines who are involved in that care will kind of follow. And so what they are is they're established deadlines for certain things to be accomplished or to be met on these patients before they go home. Okay. Things, it might talk about when does discharge teaching need to be done before they go home? When is the patient's Foley catheter taken out? When is their IV taken out? So they may be considered orders in some respects, but they're more just some guidelines of where patients after certain procedures or certain illnesses, where they should be progressing at in a timeline. Okay, It helps us to keep these patients on track, and it makes sure that we meet deadlines and that we're encouraging and we're pushing our patients to where they need to be. A nurse completes a nursing history form when a patient is admitted to a nursing unit. Completion of this form provides baseline data that you use for comparison when a patient's condition changes. Acute and critical care nurses commonly use flow sheets and graphic records to document physiological data and routine care. We will be doing a lot of documentation on flow sheets and graphic records in the electronic health record. This is where all of our vital signs go. This is where all of our pain assessment goes. This is where the intake and output records, so what these patients are taking in as far as their fluids, their IV fluids, their output, such as their urine output, drainage from maybe a drain, blood sugars, this is where we would document those, and on and on. So flow sheets allow us to quickly, through either a checkbox or drop-down box, to document measurements so that over time we can trend them. So trending somebody's blood pressure. So many hospitals now have computerized systems that provide information in the form of a patient care summary. And we used to refer to this as somewhat of a Cardex when it was a paper trail that is often printed for each patient during each shift. And we use it as kind of a help with giving report. The summary automatically updates as nurses make decisions and data and are entered into the computer. Each clinical care guideline facilitates safe and consistent care for an identified problem by describing or listing institutional standards and evidence-based guidelines that are easily accessed and included in a patient's EHR. Okay. So standardized care plans or clinical care guidelines are pre-printed, established guidelines used to care for patients who have similar health problems. Pneumonia, okay? A patient comes in with chest pain. A patient had a heart attack or a myocardial infarction and they needed a cardiac catheterization or an angiogram. Those patients may have the same standardized care plans. So after completing a nursing assessment, the nurse identifies the standard care plans that are appropriate for the patient and places that plan in the patient's medical record. Discharge documentation includes medications, diet, community resources, follow-up care, and whom to contact in the case of an emergency. The development of a comprehensive plan for safe discharge relies on interprofessional discharge planning. The development of a comprehensive plan for safe discharge relies on interprofessional discharge planning. For telephone calls made to a provider, make sure to include when the call was made, who was called and to whom information was given, what information was given, and then what information was received back. Telephone orders occur when a healthcare provider gives an order over the phone to an RN. Verbal orders occur when a healthcare provider gives therapeutic orders to an RN in person. With the creation of the electronic health record, we really don't do verbal orders anymore. Physicians, advanced practice nurses have the capabilities to put in orders from wherever they are, really. And in some circumstances, they have access at home. Okay. In some institutions, with certain situations, such as getting a consent over the phone or getting certain orders, we do have to make sure that we've got a witness or a second person getting a telephone order. So we need to check policy. So when the nurse receives a telephone order and enters the order into the computer using the CPOE, which is referred to as the computerized order entry, they need to do it as soon as possible. Okay. After they take the order from the provider, they need to read it back using the read back process. So we read it back and then we clarify and verify what was said, right, for safety. All right, so let's talk about incident reports. Incidents or recurrent reports are used to document any event that is not consistent with the routine care of a patient. So when the incident occurs, such as the biggest one that we see is a patient falls, or there was a medication error, or trying to think what another one would be. Perhaps a visitor falls or something of that nature, or there's an accident with an IV pump. We need to make sure that we document an objective, factual description of what happened and what was observed. We need to always make sure with an incident or an occurrence report that we're doing it in the appropriate system. There is always a separate place for us to document an incident report. It does not go in the medical record. There is a separate software or documenting system for incidents or recurrent reports. Okay. Typically, when we fill out an occurrence report and we document a very descriptive event of what happened, that information will then go to the administration of the unit and will go to the risk management department. But it is not prudent and it's not something that we do. We do not document that an incident report was filled out in the medical record. We document the incident. We document that maybe the patient was found on the floor, what the assessment found once we found the patient, and what that we notified a physician or advanced practice nurse and what orders were given to us. But we never make any type of mention of an incident report. And it's really not that, I guess, that big of a deal to find out why. We just want to make sure that we're not doing double documentation. We're already filling out an incident report in a different software. Okay, so that is being done. So that's an important key for you to remember. In the event that there is an incident or an accident or an occurrence with your patient, you document it, you notify the charge nurse, administration will be made aware, risk management, they'll look into it, do a root cause analysis, but you're not documenting that you filled out an incident report in the chart. You're documenting the incident, but not the actual incident report. Key to remember. So incident reports in this separate software contain confidential information. Distribution of the report is limited to those who are responsible for reviewing the forms. And another thing to consider is that incidents or recurrent reports are not considered punitive, right? The majority of the errors that happen in healthcare, believe it or not, are system problems. They're not individual people problems. So they want you to report errors because that's the only way to fix them. So it's not considered punitive. So it's better to fess up and admit that you've made an error because in the long run it helps the healthcare system. So information technology refers to healthcare informatics is the application of computer and information science in all basic and biomedical science to facilitate the acquisition, processing, and interpretation of health-related data. Nursing competence in healthcare informatics is becoming a priority as healthcare providers and facilities across the U.S. implement electronic documentation. To become competent in informatics, you need to be able to use evolving methods of discovering, retrieving, and using information in practice. It's not just enough to say, I know how to use a computer, so now I'm competent in informatics. Okay? We need to be able to recognize when the information is needed and have the skills to find, evaluate, and use the information effectively. It's important that you know how to record, interpret, and report data and critically think and apply that knowledge when providing patient care. Data include numbers, characters, or facts that you collect according to a perceived need for analysis and possible action. Clinical information systems are programs that include monitoring systems such as a computerized order entry systems, okay, laboratory, radiology, and pharmacy systems. A monitoring system includes devices that automatically monitor and record biometric measurements such as vital signs. Okay. The devices electronically send measurements directly to the nursing documentation system. Order entry systems allow nurses to order supplies and services from other departments, like a central supply place where we get all of our paper resources. Computerized order entry systems allow healthcare providers to directly enter orders for patient care into hospital information systems. In advanced systems, the CPOE, or the provider order entry, has built-in reminders and alerts that help a healthcare provider select the most appropriate medication or diagnostic test. The direct entry of orders eliminates issues related to illegible handwriting and transcription errors. Potentially speeds the implementation of order diagnostics and treatment, which improves staff productivity and saves money because we no longer need somebody transcribing written orders. Clinical decision support systems are computerized systems used within the healthcare setting to aid and support clinical decision making. The knowledge base within a CDSS, clinical decision support system, contains rules and logic systems that link information required for clinical decision to generate tailored recommendations for individual patients, which are presented to nurses as alerts, warnings, and other information for consideration. For example, a lot of the clinical decision support systems, such as alerts, that I would see is if your patient's at risk for developing pressure ulcers, it will remind you that that patient was in fact on that protocol. It may do the same thing when the patient is on a fall protocol. It also might generate reminders of the length of time a Foley catheter has been in to remind you to take it out. So these might be specific examples of clinical decision support systems. The nursing process design is the most traditional information system. It organizes documentation within well-established formats such as admission and postoperative assessment problem list, care plans such as nursing care plans, intervention list or notes, and discharge planning instructions. The nursing process design facilitates the following: generation of a nursing work list that outlines routine scheduled activities related to the care of each patient, documentation of routine aspects of care such as hygiene, positioning, fluid intake and output, and blood glucose measurements. Progress note entries use narrative notes, charting by exception, right? So only if the event that something is wrong, everything else is within defined limits or within normal, and our flow sheets. Remember, flow sheets or our graphic sheets are where our vital signs, intake and output, pain assessments, blood sugars are all documented. We also see documentation of medical administration, okay? All of this is what we're talking about is essentially the electronic health record and what we as nurses are responsible for. So it's all dispersed throughout Epic, okay? The information system allows a user to select one or more appropriate protocols for a patient. Standard healthcare provider order sets are included in the protocol and automatically processed. Order sets can be geared towards procedures, surgeries, diagnoses, medical diagnoses, such as pneumonia. A patient comes in after an appendectomy. So standardized healthcare provider order sets, as we said, are included in the protocols and automatically processed. Integrates appropriate information into the medication delivery process to enhance patient safety. Identifies variances of the anticipated outcomes on the protocols as documentation is entered. Some specific advantages include better access to information, enhanced quality of documentation through prompts, reduced errors of omission, reduced hospital costs, and because we're saving time and things are a lot more streamlined, we have an increased job satisfaction. So many nursing clinical information systems include content-imported technologies that allow the use of templates, automated data points, and the ability to copy forward either parts of the entire nursing shift assessment that enables nurses to quickly document their assessment or the care they provided.